Thank you, Nick. Just on the leadless pacemaker question, it was a great review, and it discussed the Micro, which is a Medtronic product. It's worth noting that Abbott or St. Jude Medical had a leadless pacemaker as well, called a nanostim. And our center was involved in one of the studies got published in the New England Journal, and we put in close to 50 of them. If you listen carefully to what I said, they had a pacemaker called nanostim because it's actually been recalled. And it turns out recalling these things isn't so easy when it's inside the heart already. And so the good news is we've gained a world-class experience in trying to extract them and take them out. And one of the challenges is that there is a docking mechanism to remove them. And one of the reasons why St. Jude or Abbott is revising them is that sometimes breaks, and then you're sort of left trying to fish these things out from inside the heart. So I bring this up because to reinforce that with new technology, you take the good with the bad. There's a lot of potential, and then there are all the potential problems you don't realize until it's been around for a few years. So exciting, but don't jump in with both feet quite yet. Having said that, I wasn't asked to talk about pacing. I was asked to talk about drugs and innovations in drug therapy for vasovagal syncope in particular. It's the green, right? Oh, excellent. So there's some conflicts, none of which should deal with any of the drugs we're discussing in the talk today. So I think when thinking about drugs, it's worth taking a broader perspective. I think in many cases, for most patients, we don't actually understand exactly what's going on. We have a broad sense of possible mechanisms. We often don't understand how a single drug works, and there are very few studies that have ever been published looking at the interactions of the multiple drugs and herbs and hormones and other things that people can vape and otherwise ingest these days. So it is a little bit of a cauldron or either a black box or cauldron, depending on which analogy you want to go with, when we throw drugs into the mix. Nonetheless, we do it anyway. And here is sort of a traditional physiologic model for vasovagal syncope. There are limitations to this model. It's a modification of what's referred to as the Sharpey-Schaefer model that was developed over 60 years ago. Clearly, we need to come up with something better, but we haven't. So this is it. And in blue, we have different putative mechanisms, volume depletion that was alluded to, and fluid shifts, an increase in sympathetic tone and catecholamines, baroreceptor activation, and ultimately reflexes happen involving the carotids and the aortic arch, and we think that there's a combination of one or both of increased vagal stimulation and heart rate slowing. Maybe pacemakers will help if that's the only thing going on, but often some form of sympathetic withdrawal that can affect venous return or blood pressure afterwards. So a lot of the therapies I'm going to talk about actually fit within this grid. By way of background, beta blockers have probably been one of the more studied agents. And I think you've seen a version of this slide. This is from the original POST study, or the prevention of syncope trial, that compared metoprolol to placebo. The metoprolol is in red if you really care, but the beauty of this slide is it doesn't really matter which one's which. The survival curves are almost superimposable. So it doesn't matter what you got, you fainted at the same rate. I believe the ESC used this to put the nail in the coffin of beta blockers and made it a class 3 agent at this point. But there is a wrinkle that you may see one day. There is a wrinkle, and there was actually a pre-specified analysis based on age. The cut point was 42, which seems like a bit of an odd number. I will tell you that Dr. Sheldon is a huge fan of The Hitchhiker's Guide to the Galaxy, but he tells me that wasn't the reason for this cut point. There was actually some preliminary non-randomized data suggesting that there's an age cut point before this, so this was put into the study. And what you'll see here is that if you were young, defined as under 42 in this group, you should have asked for placebo, right? The metoprolol actually seemed to make things worse. However, if you were old, and sadly I'm in the old group, for the purpose of vasovagal syncope, it starts pretty young, there was actually a trend, non-significant, but a trend towards benefit with metoprolol. And then if you bundled those data with some non-randomized data that had been collected beforehand that showed something similar. What we found is that in the younger group, metoprolol actually makes the fainting worse or increases the recurrence rate. But in the older group, metoprolol may actually make things better. Right? So this is, meta-analysis. The beauty of meta-analysis is it's eminently publishable, and it truly is the epitome of garbage in, garbage out. So this is actually being tested right now in a prospective randomized trial. And this is a post-5 study. I believe Nick is an investigator, yes? Boone? No, maybe? So, there are sites in London. We'd love to have more patients in this study. So this, basically, it's silly to have an inclusion criteria of over 42, so they rounded down to 40. But basically, if you have a patient with vasovagal syncope over the age of 40, they can be randomized to metoprolol or placebo, and we can see if it does work in this group. What about the volume depletion portion? So we clearly tell everyone to pickle themselves. Everyone gets a lot of salt and a lot of water. As Boone said, this is, you can really embrace this. You will be one of the few doctors that ever tell a patient they can take more salt. Right? If you can tell them to take more salt and take really sweet desserts, they'll love you. Right? I mean, you've sort of violated all the American Heart Association rules, but in this autonomic sphere, there are actually things that are beneficial from these otherwise villainous entities. But I'll talk a little about fludrocortisone or Florinef. This is a synthetic version of aldosterone, so hormones designed to retain the salt. I view this as part of the salt and water strategy. And what I mean by that is I find it galling, with apologies to Nick, that I see patients on fludrocortisone that have never been told to increase their salt and water intake. It's not a drug to be taken in isolation. I view it as part of the strategy, the top tier of the strategy, in fact. But what about Florinef? So this was tested in the second prevention of syncope trial, or post-2. These patients were a little bit younger. The median age in the post-study was in the early 40s. These patients were a little younger, probably because we would not include patients with hypertension. And so obviously as patients get older, there's more hypertension, so less qualified. There were over 200 patients studied worldwide. And these patients fainted a lot. The median age of onset was 17. They'd had 15 lifetime spells, right? So this wasn't the person that fainted just once or twice. They had a median of 4 faints in the last year. I think you've seen this slide as well, or a version of it. So this study was published in the Journal of American College of Cardiology a few years ago. It may have been beneficial. There was a 30% risk reduction, give or take. But the p-value was on the wrong side of 0.07. So I think there are a couple of tacks you can take when this happens. The first is to rail against the tyranny of 0.05. There are statisticians that will agree with you that it was made up for the wrong reasons in the age before computers. But you won't get very far, right? I mean, really, we're stuck with 0.05 as the threshold. So instead, let's focus on this. So if you look here, there was a fairly high recurrence rate in the first couple of weeks of starting therapy. Now, in this study, Florinef, unlike midodrine, doesn't work instantly. Florinef is basically, it's a hormone. It goes in and it takes time to retain the sodium. An effective steady state, not the drug steady state, but the effective steady state, the 5 half-lives, is actually just a little under a week. And so the way the study was designed, patients would start on 0.1 milligrams per day, wait a week, they'd be assessed to make sure they tolerated the drug, they'd have their potassium checked to make sure they weren't hypokalemic, and then dose was titrated up to 0.2 and then checked again in 2 weeks. So we actually had a 2-week dose titration phase in the study. And if you actually censored the events, those early events in the first 2 weeks, the benefit was actually greater, and this difference was statistically significant. If you actually just looked at the patients that you were able to get up to the target dose, which is mandated in the protocol, but life gets in the way sometimes, the benefit was even greater. Right, so what do you make of this? I mean, one could argue if you're a strict trialist, Florinef doesn't work, let's move on. However, if you have these patients in clinic and you have to do something at some point, I think the truth is that Florinef probably does work. Perhaps we were a little ambitious in terms of the effect that we were hoping to get. But realistically, I'd give it at least a couple of weeks before you give up on the drug, because it does take a few weeks for its effects to filter in, percolate in, and do something. And then what about mitogen? So we've talked about a little bit about pacemakers and if you have a cardio-inhibitory or vagal response. What about the sympathetic withdrawal? And we've mentioned mitogen. And I'm not going to say too much about it except that this is actually the drug that was studied in the 4th prevention of syncope trial. And I apologize for missing the 3rd. The 3rd actually wasn't a vasovagal syncope study. It was a non-vasovagal syncope population. But once you have a franchise, you want to sort of stick with it and continue the numbers. So post 3 doesn't apply here. So this study has actually completed enrollment and has just recently completed follow-up. So the data is being cleaned right now. The hope is that it may be presented by the end of the year, Bob, or early next year. Certainly within a year from now, it should at least have been presented, and perhaps as early as 6 to 8 months from now. So we'll have some answers hopefully soon. So I'm going to shift gears a little and go off the grid. So one of the challenges in vasovagal syncope is that drug companies don't care about us. Generally, I feel unloved when I deal with the drug companies. Right? No one's developing medication for vasovagal syncope. All the stuff we're using is really off-label. And so we have to take the drugs where we get them. So I was intrigued actually by this, one of the studies by a group of German colleagues published over 15 years ago now. And of interest, actually one of these studies that actually led me sort of down the path to go do a research fellowship where I did. And what they found is that in a series of studies that were tilt table based with healthy volunteers, when they gave drugs that block the norepinephrine transporter, and we'll get into what this is in a moment, that they did crossover tilt studies with placebo and the norepinephrine transporter, and what they found is that with the norepinephrine transporter, the patients actually tolerated the tilt table test, so survived the tilt table test much better than with placebo. So it seemed to prevent tilt table induced fainting, but in people that have never fainted, right? But where they caused it. It's at least intriguing and sort of raised some questions as to whether this is actually going to be important in syncope or not. So this is a norepinephrine. This is a sympathetic synapse. So presynaptic end, postsynaptic end. These are your alpha and beta receptors, the business end of neurons. So these norepinephrine lives in little vesicles, and they get released, into the synapse. Now the problem with any nerve synapse is that when you release a neurotransmitter, you have to get rid of it, right? Otherwise, you can do it once in your life, and that's not very good, right? And there are different mechanisms for that. But in the case of norepinephrine, a lot of it, the vast majority, normally 80+%, are taken up by these presynaptic vacuum cleaners, if you will, called the norepinephrine transporter. So their job is what the vesicles giveth, these taketh away, right? And so that's how it gets cleared. Now, if you actually block these norepinephrine transporters, the norepinephrine gets released, but more of it actually can't get taken up, so more of it ultimately lingers, and you get more effect on the postsynaptic terminals, on the alpha and beta receptors. So the net result is that you get more bang for your buck. Every time the nerve fires, you get more lingering effect with this approach. So this is non-randomized work done in Dr. Shelton's clinic a few years back. So he took sort of the fainters that didn't respond to anything and were desperate, and gave them increasing doses of sibutramine. So sibutramine was a drug that's a norepinephrine transport blocker that was on the Canadian market for obesity, I believe, treatment. And so he did these nice dose escalation studies and showed that the burden of fainting in 4-week chunks decreased at lower doses and even more at higher doses of sibutramine. Not everyone tolerated the highest doses. I think we lost a person here, but for the most part, there was basically a dose response that was clear. This was great. We found the new therapy for syncope. So the problem is that, again, drug company didn't care about syncope. They were doing it for obesity. They had this nice big trial, and it turns out it knocked off a few people with cardiovascular events, and they ran, and the drug's off the market, right? So our syncope patients still struggling. So we went to the next drug, and the drug that we have looked to study in what we're referring to as the post-6 study, which is a tilt table-induced study, is a drug called atomoxetine. So this is basically our version of reboxetine, which we don't have in North America. I don't know if you have atomoxetine here. It's actually approved for attention deficit disorder in North America. And so this study was a double-blind study, 2 doses and then a tilt table test, so a very acute study. And we ultimately studied almost 60 patients with vasovagal syncope that were randomized. It was a tilt test endpoint, so we don't have clinical data, and they were inclusion was based on a combination of clinical faints as well as the syncope symptom score, which pretty much gives you a diagnosis of vasovagal syncope in a structured way. It was a multi-center study in Canada with Calgary, Hamilton, Sherbrooke, and Montreal, so 4-center tilt-based study. The design is here, so the randomization wasn't perfectly equal. A couple more people sort of snuck in with atomoxetine, but basically they took pill the night before, pill the morning of, and then had a tilt test, and we waited 60 minutes. We didn't give drugs, we just waited 60 minutes to see what they do. You can see the patients were distributed or randomized fairly effectively. And this is what we found. So if you look at syncope as the primary outcome, did they make it through the 60-minute tilt or not, the atomoxetine significantly improved the syncope-free survival compared to placebo. Yay. But when we looked at pre-syncope, and we were bastards, honestly, with this tilt, because a lot of people, patients feel unwell and they feel sorry for them and put the tilt table down. We learned early on not to do that. We didn't put the table down until they either fainted, they were out, or they said they're done, right? Those are the 2 things. We didn't base it on the pressure drops, they looked a bit unwell, their sister, whatever it is, they had to go out. And so we were able to separate these 2 outcomes. And what we found is atomoxetine did absolutely nothing to prevent pre-syncope. And this isn't sort of a little bit vaguely unwell pre-syncope. I'll show you what it looks like in a moment. But it prevented syncope but not pre-syncope. And why is that? So this is sort of an example from one of our patients in the study of when they fainted. So you can see a heart rate channel here, blood pressure channel here, continuously monitored, and the tilt table. So tilt table is up here and tilt table goes down here. You can see that at the time of fainting, there was a big drop in blood pressure, big drop in heart rate. They fainted. We put the table down because they were out. This is what the pre-syncope looked like. And you can see that, table was up, the blood pressure dropped a fair bit, the heart rate actually didn't bottom out, and they didn't pass out. So we just sort of waited and kept the table up, and their blood pressure recovered. And then they went on for quite a while. This was a 60-minute tilt, right? This happened about a third of the way in, and they, after a few minutes, they actually felt largely better. And they made it through. So this is a reaction that I'm not sure that I have never seen before this study, right? Usually the traditional response is you get pre-syncopal and then you faint. Here it sort of rescued the faint but not the pre-syncope. So why is that? So blood pressure, supporting blood pressure is a combination hemodynamically of stroke volume and cardiac output. And what we showed was that the cardiac output, you think atomoxetine might actually improve vascular resistance by squishing the vessels, but it didn't. It did nothing impressive for systemic vascular resistance. It did increase cardiac output, and that's what drove this increase or support in blood pressure, right? So it wasn't based on squishing. It's based on cardiac output. So again, okay, well, fair enough. What about cardiac output? So cardiac output was up. That's a combination of stroke volume and heart rate. And it did nothing for stroke volume, right? So this is not mitogen, because mitogen squishes the vessels afterwards for vascular resistance. Mitogen squishes veins to improve stroke volume. Atomoxetine increased heart rate. I have found you the pacemaker that will not lead to extraction complications, may lead to other complications, right? So really, this cardiac output, this is driven by atomoxetine driving an increase in heart rate. So from that, we concluded that atomoxetine impressively prevents tilt-induced vasovagal syncope, but not pre-syncope. It doesn't increase vascular resistance. It's not a squisher. This is basically a pharmacological pacemaker that works not all the time. The heart rate wasn't that much higher supine, but at the time of stress when it needed it, it prevented the drop in heart rate from being as severe and bought the patient a few minutes until they recovered themselves. Ultimately, that's all well and good. Most people don't come to Nick complaining that I faint on the tilt table test, please help me, right? We need to actually see if this prevents clinical faints in their real-world setting, and that's what we're hoping to be able to do soon. If you guys have extra pocket change you can spare, We'll be collecting to try and fund that study, but that's where we are. So in terms of drug therapies for vasovagal syncope, I'll just summarize by saying I didn't talk a lot about this, but I think it's really important that we get rid of offending agents. Right? Patients with syncope don't tend to tolerate diuretics. Most don't need it, and the ones that do probably still don't need as much as they're getting. Fludrocortisone, I would argue, is morally a positive study, but not legally a positive study. Right? If you need treatment, I think it does work, and it's probably reasonable to use. Beta blockers, still unknown in the older patients, but I think the nail is pretty much in the coffin that beta blockers in young people are not helpful. And atomoxetine, or perhaps NET inhibitors in general, we've only tested atomoxetine, may be a promising new therapy for vasovagal syncope. Mitidrin, ask me in a year. Thank you very much. Oh, sorry, shameless plug. So for those of you that think London is cold in November and want to get away, the American Autonomic Society meeting is going to be in Clearwater Beach, Florida. We'd love to have you there. And those that want to join sort of just an online forum where you can discuss difficult patients, this URL is a free discussion group partially set up by the American Autonomic Society. You can go and lurk and then ask difficult questions before we send you to Nick. Thank you.